Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey, and this week we're going to be discussing psychedelics for stroke healing with Dr. Stephen Zeiler. Dr. Zeiler is an associate professor and physician at Johns Hopkins School of Medicine, specializing in cerebrovascular disease, including acute stroke therapy, prevention, and recovery. He is a lead investigator for a Rose Hill Life Sciences research trial conducted in partnership with Johns Hopkins University, exploring the use of psilocybin-assisted therapy to enhance motor function in patients with neurological injuries. Now, before we get to Steve, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And as always, if you are a clinician and you would like to learn more about how psychedelics may help your patients, especially if they're already coming in asking you questions about psychedelics, then please check out the Psychedelic Medicine Association. It is our goal to get you up to speed so you feel comfortable and confident having discussions with your patients about psychedelics. You can find out more at psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us today, Steve.
I'm excited to be here. This is great.
I love your excitement. This is contagious. I would love to hear how you first got into investigating psychedelics for stroke healing.
Yeah. In preparation for our discussion today, I was thinking about what led me to this whole area. Because as my wife and daughter sometimes give me a side eye from across the room, I'm constantly reminded of the fact that I never thought that I would be giving psilocybin to stroke patients in a trial when I was, for example, in medical school or something. And this happened, my connection to psychedelics, through a fateful meeting that did not initially involve me. I have defined what is now recognized as a post-stroke critical period. And my mentor, his name is John Krakauer. This was many years ago. He was having a cocktail at some sort of Johns Hopkins gala, as you do, and happened to run into Gul Dolan, who is my now collaborator. And they discussed her data in which she was able to keep critical or reopen critical periods. And he said, my goodness, I have someone you need to meet. And that's what led to us discussing critical periods, the importance of psychedelics and reopening them, and how we could get post-stroke motor impairments better.
I love it. Gul Dolan is a dream guest. So if she ever wants to come on and talk about critical periods, please let me know. Oh, I love that. So you came at it from, you are a stroke specialist, and psychedelics just happen to be, as opposed to a lot of people come from the psychedelics and they're like, let's see what we can do with these psychedelics. You came at from the, we know what the problem is. Can psychedelics be a tool to help address what goes on? And so if patients don't know, can you talk a little bit about what happens when, I said patients, if listeners don't know, can you talk a little bit about what happens when patients have a stroke?
Yeah. Yeah. And this really sets up why we think this whole intervention is likely to be important, right? So as a stroke physician, I care for these patients during what I define as the three different epochs of stroke. And the first is what you hear about the most. Somebody has an acute attack, and typically, although not always, but typically half of their body stops working. An arm stops, a leg stops. You can't see half of the world. And as an acute stroke physician, my colleagues and I want to get blood flow back to the brain. We want to prevent the brain from dying. You want to heal what's left in the midst of that stroke. That's the first epoch. The second epoch is managing the patient through those next many days, making sure that we protect their brain, making sure that we protect them, and finding out why the stroke happened. It's during that period of time that we set them on their recovery journey. And that's what leads us then to the third period of stroke, where we're no longer necessarily worried in the majority of patients about the stroke itself getting worse. And by that period of time, they're usually on interventions to help reduce the risk of stroke. But what has been a little forgotten about in a lot of stroke management situations is helping the person get over the deficits with which the stroke has left them. And if you can't move an arm, you can't move a leg, that's a big deal. And we are not quite as good at addressing some of those problems. And so as a stroke physician, I see this every day, and I see us doing time period number one and time period number two, and then things kind of trail off during time period number three.
Got it. And even take just a step back further, a stroke is when something has led to an area of the brain not having blood flow, and then that area of the brain is damaged. It starts to die off. Is that a very, if we're giving just kind of the most layperson definition, so they to explain what kinds of things we may be looking to reverse using the psychedelics.
Boy, I did something that I tell my students and residents not to do, which is don't define the problem. And you've defined it wonderfully. And that is that a stroke is the same thing in the brain that a heart attack is in the heart. Our cells, our organs need a constant supply of energy. You have to plug the toaster in, and a heart attack or a stroke is you've taken that energy supply away. You're no longer getting blood, which is the glucose and the oxygen to that part of the body, to that part of the brain. And so unfortunately, that part of the brain dies. And as opposed to other organs that kind of have a general function, we intuitively know that the brain has a parcellated function. The left part does something different than the right part. The front part does something different than the back part. And so it depends on what part of the brain has the stroke, meaning which part of the brain dies, that leaves you with the symptoms that you have.
And what are some of the early studies that have been done either in animals or by your lab, or whichever ones you choose to discuss, that have started to indicate that this may be, that certain psychedelics may be helpful in addressing those areas that have suffered the injury?
Right. And let me just jump to the end and say, and I'll tell you how we got there, that it's probably less about addressing the injury itself and more about helping the remaining parts of the brain turn on to address what's lost.
Got it.
And so this really gets back to some amazing work that has been done by pioneers in the field ever since the last century. And we intuitively know, even in the absence of injury, that the brain is great at adapting to its environment. We can learn new languages. Our arms and hands can learn new skills. We can do things that we might not otherwise know. And after a stroke, if we imagine that stroke leaves you with a hole in the brain, and it really does, the other parts of the brain can be quite good at helping to adapt to that lost function. It can help do things that other remaining parts of the brain can do, things that they might not otherwise have done. Early after stroke, there is an early time-limited period during which the brain seems to be quite ramped up at responding to those lost functions. And as a stroke physician, I get to see this, that patients in the first, especially 3 months, maybe as long as 6 months, their motor impairments can get better. And it can get better because of endogenous repair mechanisms, even independent of anything that we as a care provider or as a patient or as a therapist might do. And so my lab has an animal model that can look at that early time period, and we actually showed that this time period existed in mice, and what we might be able to do to intervene on that. It was my collaborator Gul Dolan, and because of this conversation with John Krakauer, that Gul and I decided that we would try psychedelics in animals whose motor recovery had plateaued. In other words, these are animals that had had a stroke, They had undergone some degree of recovery, but they never got back to normal. And their motor performance had stopped at a certain suboptimal level. Then we give them one dose of a very high amount of psychedelics and then provide the mouse equivalent of occupational therapy and physical therapy. Okay. And I'll never forget my fellow who was working on the animals, and because we're good scientists, she was completely blinded to the conditions that the animals had. She didn't know which ones had the psychedelic, and she didn't know which ones had saline. And we were using cocaine as a control because cocaine acts on similar receptors as psychedelics, but in a different manner. And at the end of the experiment, she called me almost in tears. And she said, Steve, I feel as though I've messed something up. She said the hyper animals didn't get better. And what she didn't realize is that it was the hyper animals that had gotten the cocaine and they didn't get better, but the psychedelic animals did. And so that was the first idea, the first confirmation of this at least hypothesis, that maybe psychedelics can really start to turn on this period of repair that we otherwise see. And so I think that's a unique idea because we're not giving this to animals, and we should talk about this some more. We're not giving this to patients immediately after stroke. We're not interfering with otherwise their recovery that happens normally in the hospital, even after the hospital. But once things have shut down, and because of the data that Ghoul and I have generated, the hypothesis is that psychedelics can reopen that endogenous repair mechanism, and it's our job to take advantage of that open critical period.
That makes sense. And kind of like when we're talking about mental health conditions, it's what you do with that reopened period, I'm assuming, that leads to the lasting change.
Boy, that is an incredibly important point. So important that the set and setting that we are creating for our human participants in the phase 1 trial centers on what we want to get better. In other words, we're not focusing, for example, on a mood disorder, but we have a trained psychedelic monitor who is an occupational therapist, and she will be providing them the idea of their arm moving again and dancing and imagine this happening again. Because at the conclusion of their trip, for the next 3 to 4 weeks, they will undergo high dose, high intensity arm recovery interventions and hand recovery interventions to capitalize on that open critical period. In other words, we're not suggesting that the psychedelic itself has some sort of magical property that would just repair the brain, but it primes the situation to allow that input that we then provide over the next many days, many weeks to affect a recovery. Right.
And if I recall correctly with Dr. Dolan's work, the psilocybin reopening window was something like 2 weeks. Is that what you're expecting to see, or is that the time period that you're going to be focusing on?
We think so. And perhaps a couple of points on that. Different psychedelics may have different time periods of openness. And some of that may relate to the strength of the psychedelic effect. Point number one. Point number two, translating that data from rodents to humans always comes with a bit of fuzziness just because of metabolism and the different physiologies. We think that there will be an open critical period for at least 2 weeks, perhaps as long as 4 weeks.
Very nice. And speaking of, how did you choose psilocybin as the starting point to investigate?
So in animals, we've used a number of substances, and we've seen similar results with some differences, but mainly similar results with MDMA, ibogaine. Psilocybin made sense for a number of reasons. And a lot of it had to do with the fact that in some states it is becoming decriminalized. And perhaps the most important reason is that we are partnering with Rose Hill, who is funding the trial. And Rose Hill is a supplier of psilocybin.
Very nice. But you had seen similar things in your animal models with different, kind of across the different psychedelics. And you even said even MDMA, which has a different mechanism of action from the classicals like psilocybin.
Correct. And in other words, we don't think that it's necessarily a psychedelic specific effect. In other words, if our mechanism is true, if our hypothesized mechanism is true, we would probably see the same effect with ibogaine that we would with psilocybin. The window might be opened differently. We might have a different timing, but the effects we think would be similar. Right.
Okay. And to get just slightly into the weeds, if you can, what is the proposed mechanism that you think is behind this?
Well, okay, and there we have to be fuzzy because and what I'll say purposefully is that part of that fuzziness is a good thing. In other words, Gould and others, and I want to be abundantly clear, I have played no role in elucidating the psychedelic mechanism. I'll leave that to others. And Gould and others have done some just amazing work at looking at this, but acting through the 5-HT2A receptor and all of its plethoric downstream effects, and having an effect on extracellular matrix as well. And that's one of the things that Gould and I have spent a fair bit of time discussing. And just to make a point about that, one of the things that excites me, a stroke physician interested in recovery about psychedelics, is that they have a plethoric effect. It's not acting through one mechanism. And if we just take a step back for a moment, imagine something as complicated as the brain going through a repair mechanism. Could you imagine one molecule acting on one receptor being able to affect a recovery? That I couldn't imagine that. It's too complicated a thing. And so having something like a mechanism of action that's acting through multiple pathways, I think has to be the case if we're going to affect something as complicated as brain repair.
That makes sense. And what exactly did you see in the mice? What kind of improvements were you seeing in the psychedelic treated mice?
We have an assay that looks at motor recovery as primates. I've seen you do it as we've been on this podcast. I've done it a few times where I reach out, I grab a glass of water and I bring it to my mouth. As primates, we're pretty good at that. Quadrupedal rodents, not as good. And so we can train them to get really good at what we call a prehension task, where you reach out, grab a piece of food, bring it to their mouth. And the stroke that we induce impairs that task. And then we can measure how much recovery they get by recording with training how they improve over the ensuing days. And we saw that animals started off poorly after their stroke, and the animals that received psychedelics and received training got better, as opposed to animals that received a control input.
I have to ask, even though it is totally off topic, how do you teach your research assistants to learn how to do mouse occupational therapy?
It is a unique skill set, and it is something that is not doable by everyone. And I work with an amazing person named Malet Mersha, who has really got this down pat, and she has taken it upon herself to be the best mouse occupational therapist in Maryland, perhaps the world.
I hope it says that on her LinkedIn. That's an amazing title.
Well, and I used to be pretty good at it. I've lost that skill over the years, and you have to be consistent, not only in what you do with the animals, but even in what you wear. Even if you change your viewers might not be able to see. I don't know if there's video, but I no longer have any hair. So shampoo is not an issue with me, but even, if you changed your shampoo, they might pick up on that scent and behave a little differently. So you have to be very consistent with that.
Yeah. Very interesting. Now, does that apply when you're working with human subjects.
My shampoo, I hope
Oh,
not.
yeah. Do you need to keep your wardrobe consistent and all those things?
I don't think so.
Okay. Have you started enrolling for this study?
We have not. We are hoping to enroll our first participant in the next couple of months.
Okay. And so if anybody, is this solely happening in Johns Hopkins in Maryland?
This is a phase 1 study. It is looking at safety, and it is only at Johns Hopkins right now.
Okay. So if there's some chance that we have people who have either suffered a stroke themselves or have a family member, we'll at the end of the episode, if there's a website we can direct them to, we can do that to hopefully maybe get some people your direction. But how many people do you think you'll be looking at in this?
Yep. So this is just a phase 1 study, and for your listeners, that means we're looking at safety, and we are enrolling 20 patients to do that. And all of the data that Johns Hopkins has acquired using psilocybin and other participants, and then other studies throughout the world, shows that psilocybin is a fairly safe medicine. So we think it will be, but nobody has given psilocybin to this subset of patients that have had a stroke, which means they have risk factors for cerebrovascular and cardiovascular complications. And so we take that very seriously, and we want to make sure that we're not hurting people. And so we will be watching for cerebrovascular and cardiovascular complications very carefully.
That makes sense. And are the things that you're hoping to, the types of post-stroke deficits, I know we were talking like about motor deficits. Is that specifically what you'll be looking at, or would you also maybe be looking at speech deficits, other things like that?
Yeah, that's a great question. And that really gets at some of the mechanism of what we're going to be doing afterwards. And in this phase 1 trial, we will be collecting secondary endpoints of looking at motor recovery. And we will look at other outcome measures looking at speech and mood and things. But those are secondary outcome measures. The primary recovery intervention is motor.
Got it. And that makes sense with the occupational therapy you'll be doing, but I'm assuming that you'll be able to extrapolate a lot from how that goes with motor. And like you said, you're going to be collecting if they also have speech deficits and everything. So that will be very interesting. Where do you see this going? Like, say it's found to be safe in these patients. What kinds of in an ideal world where this is FDA approved and all that, do you see this as something that the patients maybe undergo once after their critical period has closed, or what do you think that might look like?
Yeah. So there are a couple of things that we should say about that. The first is actually the second part of the trial, right? So the first part is giving the psychedelics, and the second part is what we do once it's open. And that might seem less exciting, but it's actually, as we discussed, that's actually where we think the benefit is going to come. And because set and setting is so important, we are actually using our what's called Synergy room to affect a motor recovery here. It stands for Super Room for Enriched Neurological Repair at Greenspring, SENRG. And this is a almost like enterprise holodeck room built specifically to provide high dose, high intensity therapy in a room specifically built for post-stroke recovery interventions. And we tell people it's like your own hotel room. Imagine traveling all day, you're tired, and you finally get to your hotel room. It's not your home, but it's yours and only yours. There's nobody else there other than your therapist and whoever else you decide to bring with you, family or otherwise. And the entire room is built to encourage you to want to be there and go to the experience room, where your paretic arm, along with all its paucity of movements, inhabits digitally a playful, wonderful dolphin, where you get to see your arm perform these wonderful, athletic, skillful leaps And you then are encouraged in this enriching environment to perform this really crazy amount of time on task. So that's the intervention over the next 3 to 4 weeks. And we have data independent of psychedelics that if you want to make a difference in stroke recovery normally, even in the critical period, it's this level of activity that you need to get. And so I think that's an important point here, is that we're not just providing, quote, run of the mill occupational therapy. We are providing a, a tech inflected high dose, high intensity intervention. Now, I say that in answer to your question because where I see this going is that there needs to be specialization on both sides. Let's assume this works. And let's assume that there's great data that we're seeing motor recovery. I think what we can't immediately assume then is that the psychedelics are doing this in isolation. There needs to be an understanding that assuming our theory is correct, that there needs to be specialization to give the psychedelics. And that means all the education that comes along with it before you get the dose. And then all the specialization that comes along on the tail end of that to provide the intervention, right? And that's where I think the exciting bit could be, is that if this works, we can really help to devise this type of intervention that we would be able to provide for participants, right?
Yeah, absolutely. Would the high dose occupational therapy start after the patient has come down from their journey, or does something happen during the journey as well?
So what we've devised right now is that they would be exposed. So by the way, this technology we refer to as Bandit the dolphin. It was created at Johns Hopkins. It was overseen by a number of creators at Johns Hopkins. I mentioned John Krakauer before. He really helped spearhead this. So participants would be exposed to Bandit before the trip, so that they at least understand the rules and how to interact with Bandit. They will have the option during the trip to interact with Bandit, but there's no requirement there. We want it to be open and playful. Their first therapeutic intervention with Bandit will occur immediately once they come down, and then occur over the ensuing 3 weeks. And that data we have, we know how to provide a level of therapeutic intervention that affects a change. So that we're relying on other studies from, right?
Is that a thing that you would usually do more in their immediate, the immediate post-stroke critical open period? Okay.
And you ask a loaded question there, because even now, even with some data that exists, most patients are not getting high dose, high intensity. Anyway, this is a whole other set of windmills that my team is tilting at. You've really just hit the tip of the iceberg here, but you can see that there are a number of things that need to change about post-stroke recovery.
Yes, yes. And I'm sure we're all thinking like, wow, this sounds expensive and hard to access. And that, it comes with all those same questions that all of the other psychedelics do, is like, how do we make this accessible, both
Yes.
personnel wise, cost wise, time wise, all of the things.
Boy, you have really encapsulated that well. And each step of the way, we try to address that. Oh, we say, this is very important, but how are we going to reduce the cost? How are we going to make this accessible? And some of that is on us. Some of that is on how CMS and insurers will see this, right? So I'm glad you bring that up. I think that's incredibly important.
Yeah. And I just know that as we're coming, hopefully full steam ahead towards some kind of medicalization, that a lot of people have that in their mind. I was going to say just a little bit more about Bandit. Is this like a screen they're looking at with a dolphin that like moves as they're moving?
Exactly. This was built by a team at Johns Hopkins called Kata, by engineers and computer scientists and animators, so that this was not, for example, co-opting a commercial video game system, but it was actually developed with stroke survivors in mind. And their arm is screen captured by typical screen capture hardware. so that their paretic arm is allowed to move banded across this giant, I think we have a 120-inch projection screen so that they're immersed in this, right? Yeah, it's quite fun.
I was
I
going to say,
love
this
it.
sounds amazing. So cool.
I will provide some websites and videos so that you can link to that independent of psychedelics.
Sounds great. I love it. Anything else about psychedelics and stroke recovery that we have not touched on before we wrap things up that you think the listeners should know about?
I am excited that this is a possibility. Um, and I am excited that more and more, especially with brain interventions, both physicians and patients are understanding that it requires some degree of behavior. We have to have a behavioral intervention. We have to move in some way. And point number two is it doesn't have to be unenjoyable. And so at the same time that we're realizing that a behavioral intervention and movement is needed, I'm so thankful that we have people like Gul Dolan and John Krakauer and others of my collaborators who understand that we can encourage the patient to have an enjoyable time. They want to be involved in this repair process. And this could be a fun thing for people. I don't disagree with that.
Well, I'm very excited as well. Thank you for all this pioneering work that you and your team are doing. And like I said, if patients may be interested in learning more about potentially seeing if they qualify for the study, where should they go?
There are several websites that I can make available. The easiest is to look for Fathom, just how it sounds, Phathom, Johns Hopkins. Just type that into Google and you'll go to a website, and you can find me and send me an email.
Okay, excellent. Well, thank you so much for coming on and sharing with us. And I definitely look forward to a part two in a number of years where we get to hear the results.
I completely agree, and I really appreciate you having me on. Thank you so much.
Absolutely. All right. For everybody else out there, until next time.